And thanks everyone for joining us today. We're happy to bring you an update about our COVID long hauler clinic and some of the research we're doing here at University of Utah Health around long haulers. So to begin with, just want to remind everybody, if you could please mute yourself, and I'm going to introduce our guests. They're each going to make some brief comments, and then we'll open it up to questions, both from media and from those of you joining us on Facebook. So joining us today, we have Dr. Jeanette Brown, who is a pulmonologist and the medical director of University of Utah Health's COVID-19 long hauler clinic. We also have Dr. Rachel Hess, who is chief of the Division of Health System Innovation and Research at University of Utah Health. Dr. Brown, I'm going to hand it over to you first. Can you give us an overview of our long hauler clinic, the kinds of patients we're seeing, and what types of long-term illnesses they're experiencing?
Yes, thanks for having me today. We opened our clinic in mid-July of last year, so 2021. We've been seeing patients 4 days a week, and we've seen about 500 or almost 600 patients now. And we have about 200 that are in the process of being scheduled. We continue to see a need because we see about 5 to 10 new referrals every day. And we're receiving those from providers around the area. And then also in the process of getting these patients, when they see us, hooked in with a primary care, as this clinic isn't meant to replace primary care. And so about 10% of our patients receive a referral for primary care through our system. And then our clinic has placed about 1,300 referrals to about 35 different specialties throughout the university system. And these are a wide variety, everything from cardiology to neurology to sleep medicine are very common, and some other unusual ones. And then the average patient that sees us in our clinic gets about 3 referrals. So our clinic is helping to streamline those patients as they kind of navigate the system and help to make those referrals as productive as possible.
Thanks, Dr. Brown. Dr. Hess, I'm going to turn it over to you. One of the things, we're an academic medical center, so we have the unique opportunity to not only see patients in the clinical setting, but we're also studying long COVID. So can you give us an overview of the various research projects we have going on at University of Utah Health related to long COVID?
Yeah, absolutely. Thank you very much, Kathy, and thank you for inviting me to this event today. And thank you guys all for attending. As Kathy notes, as an academic medical center and as part of a university academic medical center, we have the opportunity not only to be providing clinical care, but to be thinking through the mechanisms of long COVID and the mechanisms of COVID in general. That's allowed us to work both from a molecular level with people doing research on the way that neutrophils respond, or how one of your white blood cells, which is called a neutrophil, responds to COVID when you first become infected, and whether or not that has consequences down the road, to other studies that look at how someone develops long COVID and who is most likely to get long COVID. We've been really privileged to work with a collaborative research group known as the NIH Recover Initiative, which brings together data from both electronic health records to look broadly at what circumstances cause long COVID, to individually enrolled cohorts. And in Utah, we lead both one of the maternal fetal medicine cohorts led by Tori Metz, and one of the adult cohorts, to be able to talk to people who have had COVID and who either do or don't go on to develop long COVID, and understand, were there things early in their infection that we could have seen either biochemically in lab tests or in other health conditions that make them at higher risk for long COVID? And how do we begin to understand the process of developing long COVID, recovering from long COVID, and eventually developing treatments based on those findings for long COVID? And so we've been really lucky at the University of Utah to be able to participate in that research, really from the basic biochemical studies through these in-person studies that allow us to understand both the COVID process and the long COVID process a lot better than we did when this pandemic started.
Thanks so much, Dr. Hess. Any of you who have questions for our two experts, please feel free to put those in the chat. I'm going to start it off with a question for you, Dr. Brown. What are the most common things you're seeing in the clinic? What are people complaining about the most, and what are some of the most serious complications you're seeing?
So we see patients that were both hospitalized and patients that were not. And so depending on the severity of their initial illness, some of those patients require a lot of physical therapy for their deconditioning and things like that. For our long COVID patients, some of the most common issues are fatigue. And we're actually partnering with the VA and the Department of Geriatrics to do a fatigue study as well. And then brain fog, or this difficulty with thinking and word finding, is very common and very frustrating for patients. We have seen what's called POTS, or postural orthostatic tachycardic syndrome, where basically heart rate and blood pressure vary significantly, and that can be very disruptive as well. So I think those are some of the biggest ones I think of when I think of interfering with life, daily life, and ability to work and things like that. So and we're taking an approach to treat people's symptoms, and try what we can while we're in the process of sort of waiting for bigger research studies and other treatment trials to come about.
And a couple questions for you here. So what qualifies a person to be termed someone who has long COVID? What are the requirements for that diagnosis?
So if you go by like the WHO standard, it's, basically 3 months after the initial infection, that symptoms are persisting. In our clinic, for patients that weren't hospitalized, we usually wait about 8 weeks, because we do know that people who are sick acutely, there will be a percentage of patients that get better, within that time frame.
Are there any trends or things that we've learned about the types of people who end up with long COVID?
There have been some interesting research studies that have come out. One recently looked at levels of immunoglobulins, the antibodies that are in our blood, and it looked at total levels, not just COVID specific, but also combined that with age, number of symptoms and an initial onset, and history of asthma, which is interesting. So maybe the immune system is sort of tilted one way or the other, and looked at like a prediction score in a population that was about 75% good at predicting who would become a long hauler. But this is still, again, preliminary research that needs to be verified, but again, could tell us, who's at risk for more of a long haul phenotype versus someone that may get sick initially and end up with us in the ICU, for example.
And can you tell us how long these symptoms have lasted? Have they lasted as long as we've had people diagnosed with COVID, or, is it a year? Or is it a few months? What are you seeing?
So it's variable, but we definitely have long haul patients that got sick in the initial part of the pandemic. One challenge with that population, especially early on, testing was super limited. And so we don't require a COVID test to be seen in the long hauler clinic for that reason. And some of those patients still have those symptoms that have persisted. It's very classic to hear sort of that those symptoms will wax and wane. So you'll have times where you feel better and other times that are worse. And then another common thing we hear is like post-exertional malaise, which sort of is a medical term in essence for if you push yourself mentally or physically, you sort of pay for it the next, hours to days.
Okay. A couple more questions for you, Dr. Brown, and then I'm going to turn it over to Dr. Hess for some questions. So let's try and get through these quickly. When we say fatigue, are we talking about general fatigue or chronic fatigue?
So it's an excellent question. There are enough of when you look at folks that have studied, chronic fatigue or there are a number of criteria that they use, and they are very similar to our population of long haulers. There's been a lot of excitement in research, associated with that and symptom tracking. And we are kind of looking to see, because this is a relatively new disease, how long this will persist for patients, which really will help enlighten us for other, I think, post-viral syndromes that are out there, not just COVID.
Okay, and are we seeing the same symptoms with the different types of variant? Is long COVID more common, for example, with Delta variant than it is Omicron? Do we know the answer to that?
We don't know that yet, and it's an excellent question. The other thing we're seeing is some of our original long haulers that got some of the early variants are now getting Omicron. And so that's a question. We don't know how that will affect them. So far, anecdotally, I've heard some people say my symptoms are really different, or maybe my symptoms are worse. And then the other question is, becoming a long hauler if you get infected after you've been vaccinated. That seems to be less likely, but again, we're still waiting for some of that population data to come out, and looking at the different variants as well.
Dr. Hess, I have a couple questions for you. So how are we recruiting people to be involved in our various research studies, and how are the different studies being performed? Are some of them just looking at data? Are some of them actually involving patients? Talk us through this a little bit.
Yeah, I think that's a really important question. Different studies have enrolled in different ways. A lot of our original work looking at some of the more biologic mechanisms enrolled people who were hospitalized primarily, as well as some outpatients who were participating in other studies that had been conducted earlier in the pandemic and asked if they would be willing to share an extra tube of blood. Other studies have been observational only. We've had studies that have enrolled healthcare workers to understand how healthcare workers who may be more exposed to COVID through their jobs develop or don't develop COVID, both develop COVID and develop long COVID. And then specifically for the RECOVER study, which is really looking in depth at long COVID, we've been enrolling people both from prior studies in this work, people who have had COVID who have been in other studies. We've been working with some of the long COVID support groups, as well as the long COVID practices at the University of Utah and throughout the Utah community as well. And then finally looking at people who have been tested within our healthcare system and asking them if they'd be interested in participating. So for that study specifically, we're trying to understand how long COVID develops. And so we are enrolling people before they have long COVID, as well as people who do or don't go on to develop long COVID, to try and understand where those differences are. I think that Dr. Brown alluded to the really exciting findings about the immune globulin levels. And so really beginning to understand whether those are spiking early in COVID, or if those were people who were just more immune sensitive to begin with, versus others who may also be immune sensitive but don't go on to develop long COVID. So we've been finding people everywhere. Yeah.
And Dr. Hess, has your team published any of their findings yet? Are there any details of the research that you're doing that you can share with us?
Yeah, so others at the University of Utah have published work looking at the neutrophil hypothesis as to how that increases severity of COVID symptoms and was associated with some increased hospitalizations. There have been publications looking obviously at the epidemiology and the kind of threshold curves and transmissibility that's come out of our Division of Epidemiology in the Department of Internal Medicine. They are outstanding infectious disease epidemiologists and have been really working tirelessly, both with the CDC nationally, with our own Department of Health locally. Our first study, or two of the studies that we did in our group, one was really early on looking at hydroxychloroquine back when that was a thing, if you remember, March of 2020-ish. And we are just getting those findings together. We actually had followed people out a year and looked at household transmission, and really continue to support the finding that hydroxychloroquine was not effective at helping with COVID in people who are not hospitalized. We also participated in a second study looking at fluvoxamine, which is an antidepressant that initially had some great properties for decreasing the severity of COVID in some initial studies, that also does not seem to be super helpful. And then we just started the RECOVER study, which is going to go on for 4 years. So we should have some preliminary data soon, but that started enrolling in December nationally. And we started enrolling in Utah in mid-January. And so nothing exciting to report from that yet on the development of long COVID, but we are excited for those data to come out and excited for people to participate. We think that the more diverse participants that we have coming from different backgrounds, different severities of COVID and different parts of the COVID wave will really help us understand whether there are some specificities around these different variants or the immune response to them, and whether these kind of exciting findings that I think that Dr. Brown alluded to regarding post-vaccine potentially conferring some benefit against long COVID, against development of long COVID, will pan out, because I know that as we've seen vaccines be good at preventing severity of illness and hospitalization, be great if they also prevented the long-term consequences of long COVID, which I know can be pretty scary.
And of course, we'll keep everybody updated as those studies get published.
Yeah.
Dr. Brown, I'm going to turn it back over to you. We have a few questions for you. Do we know, are most patients eventually getting better? Do we know the answer to that question yet, who have long COVID?
You know, one thing that's been really striking about caring for long COVID patients is the variety of symptoms. You know, you walk into the first patient's room and their concerns are smell and taste that have persisted, that are abnormal, that have persisted since, you know, the beginning of the pandemic. The next patient will be a patient, you know, that was affected a year ago that will have, you know, blood pressure issues and nerve pain. And then the next patient will have headaches or other, you know, the wide variety of symptoms. So unfortunately, I think it's going to be hard to kind of lump everybody into one category. We do see, when you break symptoms down into kind of like the organ systems that they affect, there is variable patterns, and there's definitely people that get better, you know, over the course of weeks to months, but there are folks that persist. So I think we're still waiting on some of that data to come out to have a better understanding of that question. But I think the key thing for our clinic is we want folks to understand that we're here to support them, you know, throughout that journey, and to get them access to care to treat those symptoms. I know it can be very challenging to have to endure all those things while you're waiting for, you know, the research and the understanding to catch up.
Okay. And this might be a question we'll have to get back to this reporter on, but can you describe the breakdown of ages, underlying medical conditions, gender of the patients that you've seen? Is that something that you can say off the top of your head, or should we get back to this reporter?
Yeah, I would say, you know, one of the things that I think is you know, important to know about long COVID, it's really affecting a lot of people who are younger. You know, we see patients from 18 up, you know, but I would say the average age group, and this has been described in studies as well, kind of ranges between the 20s to the 50s, more women than men, but we definitely get men. Here in Utah, I think we've seen, you know, it kind of reflects the Utah breakdown of populations that live here. So I would say kind of everybody's been affected. But also, you know, there are also challenges for folks, I think, to, you know, depending on insurance coverage and things like that, also have to navigate that system to get care. So that may be a limitation, I think, sometimes for patients we're seeing is, you know, it's going to be stratified based on who has access to care.
And then any patterns with medical conditions? I know you mentioned asthma.
So asthma, yes, but honestly, we have seen a lot of patients that really had no prior medical history prior to this that they could really speak of. And so, and you know, obviously chronic comorbidities, you know, tend to lend themselves to people to being more severely ill in their initial you know, and some of those people requiring initial hospitalization.
Okay. And I think you touched on this earlier, but what impact has Omicron had on long haul illness? Have you seen an uptick?
Yeah, we've definitely seen more people coming in. And initially, you know, our clinic was focused on sort of getting people in and helping them navigate the system and getting them plugged into sort of long-term care. We are having people that are having repeat infections with Omicron. And so I think we're working on, you know, increasing access for follow-up appointments and things like that. The challenge that I would say sort of COVID is like the gift that keeps giving. We keep having to kind of change our approach and our resources depending on what patients' needs are. So we will continue to do so.
Okay. And any connection between the severity of the COVID and long haul symptoms?
There have been studies that looked at like the number of symptoms people had when they were initially sick. One specific study that was very interesting out of the UK that was very well powered looked at patients that had respiratory illness and whether that was severe enough to get sick and go to the hospital, whether they were home with oxygen and got discharged, or whether they just had respiratory symptoms. That actually was correlated with the risk of developing, you know, cognitive defects or brain fog is the common term.
And do we know what percentage of our patients were hospitalized for COVID before being treated at our clinic, at our long hauler clinic? Do we have the data point?
I don't have the exact data point, but I would say a majority of what we're seeing, probably, if I had to ballpark a number, probably 80% were not hospitalized, and we see about 20 to 30%, I would say, ballpark that were.
Okay. Dr. Hess, I have a question for you. Can you go back into a little more detail and is in as simple as terms as you possibly can explain more about the immunoglobulin? I know I'm not saying that right, but can you go back to that and kind of break that down in really simple terms? What exactly were you measuring and what outcomes did you see?
Yeah, so I just want to be clear that I was picking up on Dr. Brown's reference to the immune globulin. Our research, that paper came out of the University of California, San Francisco. So that was not done in Utah. Do you want me to expound on any other research or just note that?
Yeah. Erin, if you want to open your mic for a second, do you want to maybe just ask Dr. Hess what you're trying to get at with your question there? Do you want her to expand on that a little bit more?
Hi, Dr. Hess. Sorry, this is Erin Alberty from the Salt Lake Tribune. I was asking because I had thought that the immunoglobulin, none of us can say this, but
it's not
immunoglobulin research. I thought that was your guys's. Can you tell me? I mean, can you kind of give us? I know you went through them earlier, but I had a hard time kind of separating out like study from study. Can you just kind of give us a list of the research that you guys have been involved with specifically at the long hauler clinic?
That's a really long list. Okay. I'm gonna do a phone a friend really quickly and say, Kathy, would this be an opportunity that we could put together kind of an annotated list for this group and return that? Erin, I just don't want to undersell. I've done some of this work, but I don't want to undersell any of the work that my colleagues have done. So if we could get that back to you.
Yeah, we'll get back to you for sure.
I think generally what I'd like to be able to speak to is kind of what findings have kind of resulted from the creation of the long hauler clinic and the research and research subjects that has facilitated.
Okay.
So, I mean, just so I understand that there's probably lots of things that could tie into that, even if it's just kind of like a sampling, but especially where there's actually been findings that we can speak to, as opposed to like things that just started a couple weeks ago and we don't have any idea what the results are going to be yet.
Yeah, no, I hear you. And Jeanette, can you speak to that? Or I know that we can get that information from.
If you want to do it separately, like after this, that's totally cool.
Yeah, okay, that would be great. Thank you.
Yeah, I think we can do that for sure.
What I would say is there's no published findings yet from our long hauler clinic. We're still pretty new, relatively. We've been open for about 7 months. Most of the stuff that's been published so far was like from more of the inpatient studies, and as Dr. Hess alluded to, more the epidemiology. But I think the key is that I think, a lot of this research, like the stuff that we're doing with their VA geriatrics group, it will be applicable not just to COVID, but other, general things like just fatigue in general and better understanding of that. So I think this will be ongoing, and it's pretty exciting for a lot of patients.
Okay, thanks, Dr. Brown. This is for you, Dr. Brown, when did you realize the need for a long hauler clinic? And I know we're a multidisciplinary group, but when did you all first start to meet and realize that we needed to put something like this together?
Now, I've been really lucky here at the University of Utah. We have great leadership and support. I'm an ICU physician, so I think at the beginning of the pandemic, a lot of us were very focused on the inpatient needs and the severe illness. But I remember hearing reports from folks or from colleagues that are on the East Coast and West Coast that were reporting that initial sort of surveillance systems, and systems to extend the healthcare system process. We're talking to patients who, in theory, should have gotten better, but were reaching out and still kind of updating their symptoms weeks after they should have been, quote, better. And so we were hearing this from enough providers also internally that, what do we do with this? It's new, there needs to be sort of a centralized hub to be able to care for patients, and also put together care pathways for patients who may have never had experience with the healthcare system. Having to suddenly see 3 or 4 specialists can be complicated. So we had some of our early meetings back in December of 2020 and started working from there. But it really has been a group effort, and I've been very well supported by my colleagues and our research colleagues. And also our goal too is to educate other providers as well, so that we spread what we learn for helping patients as best as possible.
And this is a question for both of you. Dr. Hess, you talked earlier about the need for, our research will be more rich if we are looking at data from a variety of different kinds of groups. So I'm going to start with you, Dr. Brown, and then go to you, Dr. Hess. What are we doing to make sure that the research that we're doing and the care that we're providing, that we are reaching out to all different ethnic groups, age groups, that sort of thing? And why is that so important?
I think it's important because we feel here at the university that everyone deserves, as good as care as possible. And being able to access those populations, which have typically been underserved, is part of our key mission. So we're partnering with things like our geriatrics group. We're partnering with community resources that are free or are reduced cost. One of the things we're very conscientious with in our clinic is also, financial limitations that patients may have. So like access to breathing exercise programs that are free, or physical therapy that's reduced or free. Again, so that we're not just targeting people who have, adequate financial resources.
Dr. Hess?
Sorry, no problem. I think that there are several things that we've been doing in our approach to ensuring that our research population is as diverse as the community affected by COVID in Utah. The first is that we've worked with a we've worked with the community groups, including the Association for Utah Community Health Centers, to get the word out about these studies. Our research team includes people who are native Spanish speakers, which helps a lot with linguistics. But we also recognize that Utah is a rural state. And so for this new study that is coming online, it has a relatively long visit associated with it. So we've budgeted to allow people who are coming from a distance to be able to stay overnight in Salt Lake if they need to. And then we've worked to ensure that we have hours associated with enrollment that are able to facilitate people's schedules and that sort of world. I think that that probably the most important thing that we've done is ensure that we have staff that is able to meet people in the language of their choice. That has led to most of our studies currently overrepresenting our Latinx population, which initially during the pandemic in Utah was also represented in the people impacted by COVID. So we were able to represent those percentages as opposed to more typical Utah populations.
Thanks, Dr. Hess. Hey, just a reminder to our group, Dr. Hess needs to leave us in about 10 minutes or so. So if you have more research focused questions, get them in now before we lose her. And I'm going to go back to you, Dr. Brown. Are you seeing people who have eye issues? I've heard about this too. And I actually know someone who feels they've had eye issues following COVID, long-term eye issues. Can you talk about that?
That has been a complaint that patients have had. Typically, I would say I haven't heard back that there are any specific conditions that have yet been linked. But we're lucky to have the Moran Eye Center to partner with as well, so we can place referrals through there. And I think, we'll just kind of have to see. But yeah, it is something that we've definitely heard.
Okay, and can you talk about long haulers in the context of once COVID is no longer pandemic, but endemic? How will we think about long haulers when that's the case?
I think we definitely had, known of post-viral syndromes before. There are several in medicine, but one of the commonly known one would be mononucleosis or mono caused by EBV, which is also one of those viruses that's just interpopulation. Most of us have been exposed to it. So I think, there will be ongoing cases just like there are of mono. There'll be ongoing cases depending on what variant would be at play. But it'll be interesting to see if some variants have more of a tendency to create a long hauler type syndrome versus an acute illness that resolves. And we'll just have to see also too, the vaccination question is going to be key as well.
Okay, and a quick follow-up question, Dr. Brown, about the eye problems. What are some of the vision issues that you're hearing about from patients who believe that it's connected to COVID?
Yeah, people that had sort of stable vision prescriptions, for example, were then noticing that things weren't, that their eyes had changed and then needed to go see their eye doctor more frequently after that. And to be honest, I'm not an eye expert, so I defer to their expertise. But it definitely seemed like people who weren't really experiencing eye vision changes then noted them more after having COVID. So I would have to look into to see what they've found so far.
And what advice would you have for people who are talking to their doctors? They believe maybe they have long COVID symptoms, but their doctors aren't necessarily believing them, or they're not validating that it might be a long COVID issue. What would you say to those people?
So I think it's really important to consider the long COVID effects. There has been controversy in the literature about, what symptoms are directly tied to COVID. I personally don't feel it's helpful to tell someone we do or we don't know when we don't know for sure. And, it's important to listen and validate concerns regardless. When we're seeing patients in the COVID clinic, we also do have to remember that other conditions exist. So for example, one patient complained of fatigue and was found to have gastrointestinal bleeding and severe anemia. So it's important for us to remember other things exist, but it's also important to be adaptive and sensitive to what patients are experiencing. So if someone comes in and they're having debilitating headaches, well, just because it's, COVID associated doesn't stop us from, going through, headache treatments and, referring them to see our neurologist and, getting additional care. So the key is finding a healthcare team that supports you and listens to you, and you feel validated that way.
Thanks, Dr. Brown. Dr. Hess, I'm going to give you a final question. I know we need to let you go. What are the main things our researchers are hoping to accomplish through all the various research studies going on at U of U Health? What do we hope to find through all those various studies?
I think that the most important thing that we can find is, one, ways to prevent long COVID and ways to prevent these other post-viral syndromes that are likely related in some way. And then the second is, excuse me, to identify treatments that work for people with long COVID and with post-viral syndromes. So the first is, how do we try and prevent this? Some of that may be through vaccination, some of that may be through treatment earlier on. And then in people who develop long COVID, what treatments can we offer them to both improve their quality of life, but also that are potentially curative, although that's a little bit of a pipe dream maybe, but how do we start to understand how to better treat people in ways that they can get back to their normal functioning, and have this be a condition that they have, not a condition that defines their life.
It's a great way to put it. Thanks so much, Dr. Hess. We're going to let you go, and we will follow up with the various research studies we have going on right now. So those of you who've asked, we'll make that available to everyone. Thank you, Dr. Hess. And we're going to let you go. And Dr. Brown, I do have more questions for you. Mm-hmm. So one question here. We've heard of people who were generally healthy to experiencing pretty severe disability as COVID long haulers. Do you happen to, can you estimate a percentage of patients who've gotten to the point where they can't perform daily life tasks without some type of assistance or support? And are those people generally experiencing previous underlying medical conditions, or are they people who were really healthy and this just hit them really hard?
Yeah, there was one particular study that looked at patients 7 months out, and there were about half of the patients had no change in their work hour capacity, and about another about 30% had reduced work hours that they were doing. And obviously that's, dictated by your job and what you do for a living and those sort of things. And then there were about 20% in that study that were not working at the time. And this focused on patients that were in their 20s to 50s mostly, which is your prime working population. But I have not yet seen a follow-up to know if those folks got better and then went back to work, or whether, there's definitely a population that has been kind of persistently disabled from this. So we'll continue to see how that data plays out.
Okay, then can you touch briefly on some of the more unknown and perhaps, maybe they're not considered official long COVID symptoms, but what are some of the more unusual things? We've heard about fatigue, we've heard about heart issues, taste and smell. What else? I can tell you anecdotally on social media, people talk about hair loss. Mm-hmm. We've talked about these vision problems. There's the parosmia. I know I said that wrong, where your smell is distorted. You can smell, but you smell things, they smell really weird to you. Any other of these unusual symptoms? Can you touch on any of those?
So as smell and taste have come back for some patients, and these are typically patients that were earlier in the pandemic. One particular patient said to me, I had to go find toothpaste that wasn't mint flavored because anything mint flavored was horrific. It just tasted so bad. So I felt very sad for him because there are a lot of things that have mint flavoring in them. But just that concept of the things, as those nerves repair for smell and taste, they may sort of rewire funny. And so that can be pretty bothersome for patients. Unfortunately, so far, currently, there's no treatment for that. But we do evaluate folks for other coexisting conditions that may be worsening that as well. So, and then some unusual symptoms that we've seen, kind of nerve pain problem, like complex regional pain syndrome, almost or like a Guillain-Barré type symptoms where people have severe weakness, almost like paralysis, but it's not persistent, would be the other kind of unusual ones that I've seen. And
Anything with oh, I'm sorry, I was going to say anything like hair loss, ringing in the ears.
Yep. So those are actually pretty common, is the hair loss and ringing in the ears. Hair loss, we do know that that's like a post-stress response. So we see it in other conditions as well. Then typically as that stress improves, people's hair cycle will, go back more to normal. An example would be like a post-pregnancy, you'll see a lot of hair loss post-pregnancy, and then, the hair starts to regrow normally. So, and then tinnitus can be really bothersome, but that's also pretty common. It was in some of the early studies that where patients could report their own symptoms because I don't necessarily know that people would have, like researchers would have originally sort of equated those symptoms to post-COVID. So I think that's why it's been really important to involve the post-COVID community in design of our research and design of our clinical treatments, because they're sort of the ones leading the way and telling us the symptoms that they're experiencing. And I've really appreciated working with these patients as well, because they're very altruistic. Many of them have said, well, even if this doesn't help me, I want to know that this is going to help somebody else down the road. So very much appreciate that as well.
Okay, and Dr. Brown, do you have an idea of how many of your patients have not had consistent access to medical care across the board before getting care at your clinic?
I would say, being able to speak to like 10% of the patients that we've seen so far, we've referred to either internal medicine, family medicine, or geriatrics for primary care. So they didn't have primary care doctors, so they were sort of unplugged from the medical system. And it's important that, they're not missing out on things like routine cancer screening and, routine labs and other conditions to be followed. So getting them into the system is important for not just long COVID reasons, but for other medical reasons as well. And then access to the system in general has always been a challenge for people. Some may be uninsured, some may be underinsured. Job transitions, it can be really hard if people are trying to navigate, reduced working hours or not working and insurance coverage and things like that. So it's definitely been a work in progress, and we've tried to work with our case management staff for help and support that way as well.
Okay, and do children develop long COVID? And if so, what kinds of symptoms do they typically display?
Yeah, there hasn't been as much data on pediatric long COVID. We have partnered with providers over at Primary Children's Hospital. They're in the process of working out their details for seeing those patients. It's typically reported as a lower percentage of children that end up with long haul symptoms, but there definitely are children that experience that. I think the average I've seen, at least from the data, it was like about 10%, but I think there's just been less known about that and less follow-up. So I don't know if I'd hang my hat on that number.
Okay. And I'm not seeing any other questions from our group? Okay, here's one right here. The 7-month study that you
Mhm.
referred to.
Mhm.
I'm not sure, Erin, what you wanted me to ask about that. Do you just want Dr. Brown to?
I'm sorry, I was trying to type quickly before you closed out.
Oh,
The 7-month study that you referred to,
Mhm.
where 20% of the patients were not working afterwards and 30% were working reduced hours, was that a study focusing on subjects who had experienced long COVID at
Mhm.
3 months, or like the WHO definition? Or was that like anybody that tested positive for COVID? That doesn't sound right, but like, I just want to make sure that it was for people that specifically for long haul patients.
Yeah, and I can get you that study as well. It looked at patients, I thought this was a really well done study because it was an international cohort. So it wasn't just patients in the US, or what like other one specific country. It was actually a number of countries, mostly in Europe and in the US. And looked at basically there was a population that recovered in less than 90 days and a population that did recover in 90 days. And when they looked at the patients that didn't recover within 90 days, a number of them still had like anywhere from 12 to 14 symptoms. And then they broke those down into sort of what happens with those patients. And that was where they looked at, the patients that had no impact, reduced work hours, and then looked at the patients that were not working.
and Dr. Brown, what is the main takeaway you want everyone to know today about long COVID, about our clinic?
I think the key is that, we want to be here for patients that are experiencing long COVID symptoms, because we understand that they can be distressing and debilitating. We want to be able to provide care that is based on evidence, and also compassionate, and that we want to work with our research colleagues so that we better understand the different, possible mechanisms of this. And again, like Dr. Hess said, working on prevention, working on treatment. So.
Great. Well, that would be probably a great question to end things on, unless anyone has anything else entered in really quickly. But otherwise, I think we'll close it out. It doesn't look like we have any other questions coming in. So it sounds like a couple things we need to follow up on with everyone. We need to provide you with a complete list of all of our research work currently ongoing that relates to long COVID, and then a few data points about the clinic. We'll work with Dr. Brown on getting those to everyone. And of course, please don't hesitate to reach out to myself, Sue Winchester, Kylene Metzger, if you had any other specific questions that you wanted to follow up on. And so with that, I'm going to close it out. Thank you very much, Dr. Brown. Thanks to all of you for joining us, and we'll see you the next time.